Overcomers, how are you all doing? This is week 4 of the quarantine, and it's going pretty well for me. I'm trying to find blessings in all of this. So today, what am I thankful for? So I'm thankful for not driving or commuting, which is a big pain, can be in Houston, right? So welcome to our next episode of CONNECT OVAR COFFEE. We have a very special guest today, and Dr. Westin is not just a global expert in ovarian cancer, but she also serves on our leadership council and gives us utmost guidance in everything that we do. So with that, thank you so very much, Dr. Westin, for joining us today.
Thank you for having me. I'm so excited to be here.
So I have many questions for you, as always.
I love it.
So some of them are COVID, some of them are not. So I'll delve into the COVID questions as we get along. But my first question to you is the landscape of ovarian cancer has truly evolved in the last 5 years or so. So Please tell us about the new surgical advancements and enhanced recovery plans that our overcomers should be aware of.
Sure. Yeah. And I mean, you touched right on it. We have seen so much of this so-called enhanced recovery. You know, a lot of our patients with ovarian cancer have to have very, very big surgeries, and the recovery can be long and arduous. And we, over the last few years, our center, as well as many others, have really collaborated to embrace this so-called enhanced recovery, which involves things for both pre-op, intra-op, and post-operative care. But the bottom line for the overcomers is it gets you up and moving faster, it gets you home faster, it gets you recovered and kind of back to your normal life faster. And you get to take less pain medicine because you don't need it. And so it's been amazing for our patients. We have great quality of life scores with the new enhanced recovery. Patients go home sooner. They feel better. They eat sooner. You know, they're not starving. So it really has been truly incredible. And so from the standpoint of a new cancer diagnosis, it means that, certainly you may need that surgery and you may be in the hospital, but you're back to your normal life on a much sooner scale than you were before, when we were doing our traditional post-operative, where we keep people in bed for days and, don't let them eat until they pass gas, and, all of these types of things that we just don't follow anymore. And it's been amazing to see how great the impact has been for our patients. Other kind of surgical things on the pike, if our overcomers have a recurrence, there's a lot of controversy around if we should go to surgery at the time of recurrence. We got some data from Dr. Coleman and colleagues that that wasn't helpful. And so we've been kind of swinging away from surgery, although we're eagerly anticipating data this year, potentially over the next few months, from another large trial called Desktop that will give us more information to see if there's any patient population that might benefit from the use of surgery in the recurrent setting.
Thank you. And by the way, I love that necklace on you.
Thank you. It's one of my favorites.
Thank you.
You too could wear this necklace.
So with the COVID-19 outbreak, many of our survivors and overcomers are facing delayed surgeries and scaled back treatments, right? So I was reading a study by the World Health Organization that revealed that cancer patients who develop COVID-19 have a 5-fold risk of dying compared to people without cancer. Mm-hmm. And that is significant. So, but yet many patients strongly feel that, treating and overcoming cancer should come first. And that's a legitimate concern. So under these circumstances, what would be your guidance to the ovarian cancer community on this?
Yeah. I mean, this is the $1 million question right now. We are learning as we go. There are data that we're getting out of China and some of the other early COVID sites about what happens to cancer patients. And there was a small study out of Wuhan, which, as you know, was one of the first areas that had kind of the really big epidemic of this disease. And what they found was that, as you mentioned, cancer patients, if they get COVID, have a much higher chance of dying and a much higher chance of getting intubated, so getting a tube to breathe. So there's a much higher chance of those respiratory complications that are the problem. And importantly, they found in their population, and again, it was a small study, but 40 to 45% of the patients were infected in the hospital. And so that really provides kind of guidance around how can we protect our cancer patients. And so it's not that we can't treat patients with cancer. It's not that we can't treat our ovarian cancer patients. We just need to be very mindful of the way that we're treating them. So some of the guidance that I was actually a part of an SGO, the Society of Gynecologic Oncology panel for COVID around chemotherapy and clinical trials. And we've come up with some guidelines. There's actually going to be a white paper that's published in a few days. But the bottom line is you want to try to avoid contact with the hospital. And so how can we do that? We can get your labs in an outside facility. We can utilize telehealth to clear you for your chemotherapy. We can have you get infusions, maybe not at the main medical center, but at a smaller infusion center where there's less people. And if we're making treatment decisions for you, we can try to pick something that's effective, but that's also going to reduce the amount of immune suppression you have and also reduce the number of infusions you need. So for example, for a patient with new ovarian cancer, is it better to go ahead and do chemotherapy first? And if we're doing, to avoid that surgical exposure, and if we're doing chemotherapy first, utilizing a chemotherapy regimen where there's only one infusion out of every 3 weeks rather than a weekly or dose-dense regimen, or an intraperitoneal regimen that requires a lot more hands-on interaction with nursing and a lot more visits. And so making those kind of decisions so that we can get the best care, but also reduce the amount of touch and reduce the amount of exposure to the hospital. So I think that's really, those are kind of the guidelines that we're utilizing.
And in relation to that, we know that visitors are not allowed in the hospitals these days, which presents a uniquely somber challenge. And I know from talking to a few of our overcomers how emotionally draining this might be for patients that are in the hospital without visits from their loved ones. And so do you see this becoming an issue for patients, in terms of them deciding whether or not to delay their treatments and surgeries? And when do you think these restrictions may be lifted?
Yeah, this is a tough question because we really don't know how long the social distancing recommendations are going to happen. And personally at MD Anderson, we're trying to kind of flatten our internal curve as much as possible, right? So, the Harris County curve is being flattened with the stay home, work safe or stay safe regulations. But internally at Anderson, we're not a general hospital. So we won't have people coming off the streets with COVID symptoms. So we have a unique opportunity to really protect our patients by reducing kind of the in and out flow of people. And that not just only involves visitors, that involves staff. So any, I never like to use non-essential staff, but any staff that can work from home is working from home, including yours truly. When I don't have clinic or if I'm not in the operating room, I am right now in the comfort of my own home working, so really trying to reduce that in and out. And that does also go towards the patients. And it is hard when you're going through a treatment or if you've just had surgery to not have your family members there. We understand. And certainly the staff is trying to interact with the patients as much as possible to provide that, human warmth and contact. But things like Zoom and FaceTime and those kind of things are essential to, have that interaction, but it's going to be remote and we do not know when it's going to stop. I know that, our reduction in clinics and our reduction in in-person clinics is looking like it's going to be through May. This is changing on the daily, but I would anticipate as long as those reductions or those restrictions are in place for the clinicians, I would imagine it will be there for the visitors as well. So, every hospital is going to be different. Not just in Houston, but across the world, or, all depending on when, the pandemic is hitting them at the worst. And so I know here we have very tight numbers of beds and ventilators and ICU, space. And so they have really modeled as much as they can to, we're running at like a 50% hospital capacity right now. I mean, usually Anderson is hitting 100, 110% always. Our ER is always full. Our beds are always full. And so they've been really mindful of reducing, anything we can to keep those beds available if we do have a surge.
And thank you for sharing your thoughts on this, because it's an important part of the whole journey, right? Having your loved ones and your supporters around you, but it is also important for our overcomers to know that this is in their best interest at this point in time to have them at the hospital just by themselves and reducing the number of people or the visitors, even though it may be their own family members. So thank you for sharing that.
We know most of our patients, our overcomers, are sheltering at home. So the only time they're going out is when they're going to the hospital to get their treatments. We absolutely want to avoid any internal hospital spread. That's what we want. I mean, you guys are doing an awesome job limiting community spread by staying at home, minimizing visits outside. We cannot let people get infected at MD Anderson. That would be absolute disaster. And so that's why they're doing what they're doing. But we get it. I know it's devastating. I was talking to a new patient and she's like, I wish my husband was here. And it's just such a tragedy, but at the same time, we can't take a chance of, someone not, especially since we know, depending on the data you read, like 30 to 40% of patients can be asymptomatic and spreading. They may eventually become symptomatic, but there's a huge, gap, in that time period. It's not like people only become infectious when they're already symptomatic. And so we can see asymptomatic spread, and that's a huge danger.
And since our last Connect Over Coffee that I did with Dr. Lewis, now it seems the recommendation is to wear masks everywhere. So he and I talked about this at our last episode, and that's when it was still not, right, suggested that everyone do it. So tell us about the effectiveness of the homemade mask, and how else should our overcomers prepare for their hospital visits that they must do at this point in time, and what precautions are being taken for surgical patients?
Yeah. So I would say at MD Anderson, everyone is getting a mask on arrival. So you don't have to wear your own mask when you're in the hospital or in the outlying clinics. So that's good. So you get
just a quick question, because we have, audience from across the world, right, that follow us. Sure. So if they're not going to a large center like MD Anderson, right, and it's a smaller community hospital that may not have that many masks available, in those situations, would you recommend that they wear something when they step out of the house?
Absolutely. Although the hard thing is the homemade masks, the cloth masks and things, they're not awesome at preventing spread. And so there's a few really important points. They're mainly to help you not touch your face. And they're also to help you prevent from you potentially infecting someone else. But the particles that are airborne and droplet-oriented particles, they can get through those masks. But it helps us remind ourselves of our social distancing. It helps us remind ourselves, okay, we have to stay safe. The problem is if you start wearing a mask and then you think you can get right up on somebody still. You can't. You can't. This is just one more extra layer of added security. So I would first say that, we don't know, the overall efficacy of these masks in preventing spread, but it's not going to hurt unless we don't distance, right? So that's one of the main things. I definitely think wearing a mask during treatment makes sense. I know a lot of hospitals with treatment are doing COVID testing before treatment. So a lot of them are doing COVID testing before surgery. So there is some testing that's going on, but we know that you can test negative and then be positive a few days later. So, you just really need to use an overabundance of caution. Hand washing constantly. Don't touch anything you don't need to touch. When you get home, if you have gotten a treatment, so say you went into the hospital and got something, strip all your clothes down. If you can do it outside before you come in, that's great. Just to avoid hopefully spread to family, and also to avoid spread. If it is on your clothes, you can take it off, throw it right in the shower, in the laundry, and get in a shower, and you haven't touched anything else. If you come in with your clothes and you sit down in a chair, this virus can live on what so-called fomites, so non-living things, for 3 days, we think. So, you can easily spread it quickly. You want to wipe down your phone. You want to, take minimal, don't wear jewelry, no watch like I'm wearing right now. You want to avoid all of those kind of things. Anything that potentially could have virus on it, you want to try to avoid even leaving the house with it. But then if you do come back in the house, get all that stuff, wiped down and cleaned, and get yourself a hot shower before you kind of interact with the rest of your family. And the same thing goes for like, if your family members are bringing groceries in, those kind of things. I mean, we are wiping everything down that comes in from outside the house, mail, packages, everything. We have one person that kind of does all those things, wipes them down and brings them in because we're being so strict, especially because my husband and I are both physicians, so we cannot have any inner family spread. It will be disastrous.
Yeah, receiving and doing grocery has now added that extra layer of stress
Yes.
to everyone's lives, right?
Yes.
It's like, it's not just doing your grocery and bringing it back in. It's like you have to wipe everything down and make sure, wash your produce and the vegetables
Yes.
and everything, and then bring them inside the house. So it's like another 1.5 hours that you have to do.
Oh my God. The groceries are a whole job.
Right? This is a question that, I know that we wouldn't know the answer just at this point, but I'm going to ask anyways. Do you think that the cancer survival rates might fall if this crisis causes delays to diagnosis and treatment and critical interventions required to diagnose and intervene in early stage ovarian cancers, meaning that if we are getting delayed in detecting ovarian cancer early, are the survival rates now then expected to decline over the next few months or perhaps even a year or beyond?
Yeah, well, I mean, I think a lot of it's going to depend on how long we have to do this distancing and how long we have to kind of change our practice so that we're minimizing, because obviously our early stage patients are going to have minimal symptoms. There's symptoms, but there might be minimal. And so it might not be enough to where they're really push their, say, gynecologist or internal medicine doctor, like, I really need to come in for imaging. It might be one of those things that someone says, oh, come in a few months. And that, definitely could be that critical juncture between being diagnosed at an early stage versus diagnosed at a later stage, which the majority of our overcomers are. So that definitely could have an impact. It also, if surgery is even more limited. So there are some institutions in New York and other places that they cannot do any surgery at all. They do not have ventilators to do that. We're hoping that is not what's going to happen across the country. We're hoping that hopefully we got out in front of it, like in places like Houston and in other cities like California, and that, that's done very well with flattening their curve. So we're hopeful that that's not going to happen everywhere, but we don't know. And so obviously surgery is a mainstay of treatment for ovarian cancer. And without being able to have surgery, it potentially could impact outcomes. So a lot of it's going to depend on how long we're having to do these new measures to see what kind of impact it's going to have on kind of survival when we look at it down the line. If it's only a few months, we might not see much of a difference, but if it's, extending out, some of the projections show that these types of measures are going to have to go on for like 18 months, obviously not consistently, but all, on and off. That could definitely have an impact. And if people aren't seeking care, if people aren't able to receive the care they need, you could see how this would potentially affect survival. Of course, I don't know that we've ever seen anything quite like this in the modern time that we can say, oh, it'll be similar to, when this happened.
Right.
We really don't have any frame of reference.
Yeah, we are certainly living through history at this point.
Yeah, we are.
This question is on clinical trials. So tell us about the current state of clinical trials in ovarian cancer with so many remarkable advances that are being made. How may our overcomers stay informed about the ongoing clinical trials, and please share the most promising studies that are in the horizon?
Yeah. Well, I mean, I think, everybody is very excited. We know we've had tons of FDA indications around PARP inhibitors. So these are oral medications that are very effective for patients with ovarian cancer, both in treatment, meaning if there's disease that needs to shrink, and also in maintenance, which means you've had treatment, surgery, chemotherapy, whatever, and now we're trying to keep the cancer away. So that's been the most exciting. But, it doesn't work for everybody, okay? Or it doesn't work forever for everybody. So we obviously want to do better. So there's a lot of interest around overcoming resistance to these drugs and really looking at different combination strategies. So combining PARP with other agents that target other survival pathways for cancer or the immune system or things like that, that will help everybody benefit. And so that's where some of the most exciting data are for ovarian cancer. I'd be remiss though if I didn't talk about research in the time of COVID. It's changed, so some institutions are continuing on full force with all their clinical trials up and running. Others are limited to just a few. Others are completely shut down. Again, it depends on kind of what the COVID burden is in that region or what the projections look like. So really the best first place for an overcomer to find out what's going on is their doctor, asking, is there a clinical trial option for me? If there's not one here, is there something else where I would qualify somewhere else? We don't all have the ability to travel, but if you do have those opportunities, you potentially could consider that. There are a number of really cool websites, Foundation for Women's Cancer, a lot of the different Ovarian Cancer Research Foundation, they have links to different trials. If you're really savvy, the NCI, the National Cancer Institute, has an awesome search engine where you can learn about that. If you really want to learn, the next time we have an in-person Ovarcome meeting, I've done this where I do a little test drive and take you through how to search for clinical trials. I'd be really excited to do something like that again, maybe over Zoom. Renzi, we can share my screen. But in all seriousness, we can do, I can teach you how to search. So there's lots of different ways depending on kind of how savvy you are internet-wise. But the first line really is to talk to your doctor and find out, what she or him have for you that you could look at.
Okay. This is my last question. Please share something positive with our listeners and tell us, what would be your parting message for our survivors and overcomers, not just for today, but not in the times of COVID, but in general going forward?
I would just share that I had this overwhelming feeling of hope that we have, looking back at what we've been able to do over these last 5 to 10 years and looking forward at where the science is. I just think nobody wants to have cancer, but this is a time where we are making great strides and we are helping people live longer. And so we have great hope that we are really taking down this disease. And of course, I'm at MD Anderson. We always talk about making cancer history with the line through cancer. That goal seems so much more achievable than it did even just a few years ago with ovarian cancer. And so just, stay positive, do what you can. Don't sweat the stuff you can't you can't control, and just show up.
Thank you so much, Dr. Westin. This was so informative. And as always, you always have so much great information to share with us. So thank you for your time. And Overcomers, I hope that you really enjoyed this conversation with Dr. Westin. And if you have, your social platforms, Twitter, Instagram, or Facebook, just make sure that you share this brilliant information that Dr. Westin just shared with us so that more and more Overcomers will benefit from this fantastic knowledge and information that she just talked to us about. So thank you, and we will be back soon with our next Connect Over Coffee. We'll see you then. Thank you.
Bye.
Bye.